So, and there's the official kickoff. So hopefully everybody's okay with that. And just want to say thank you everybody for joining us tonight, from the MacOrtho group and across Canada. And I think we're actually getting a pretty good global audience going on. And so thank you everybody for sharing your evening with us. I'm really excited about tonight's talk and tonight's panel and tonight's topic, really, patient recovery following trauma. And we'll give a brief intro to that sort of as we get going here. And I just want to make sure we're ready to go to the next slide. So it's, part of the ongoing shift, as we were sort of just chatting about before we got started here, of the transition to real life podiums to the virtual platforms as we all sort of deal with what this pandemic is throwing at us. But, at the McMaster, we've sort of taken that as an opportunity to really connect, and we've connected across the other subspecialty. And as we sort of got to trauma, we thought about how let's connect with some of the networks we share a lot of our successes with, and that includes, COTS and really global audience. And we have some of our residents, Dr. Dan Axelrod and Marianne Cotier, and they've really taken initiative to help us in setting this up and helping us connect with some really great lectures. And this is, the schedule and the program that we have laid out for everyone over the next few weeks. And it's meant to be really bite-sized chunks and discussions around important trauma topics spread out over a few weeks. Every 3 weeks, we're going to have a dedicated case session. So, these sessions like tonight are sort of meant to be a discussion about different concepts. And then every third week or every fourth week, we'll have just dedicated cases where residents and fellows will sort of present to a panel of experts, and we'll hopefully get some really interesting discussions going on there. Just a reminder for tonight, the event is being recorded, as you may have heard at the beginning. When you have the presentations, just mute and keep your videos off, just so we can direct the attention to our incredible speakers. And then when it comes time to the discussion, unmute and get involved. Ask questions through the chat. I'll be trying to monitor the chat, or just unmute and ask a question and raise a hand. So there's multiple ways to sort of get involved. Eventually, one day we'll have everything, sort of all these recordings available, and hopefully you get a chance to sort of review something you want. As a brief introduction for those of you who don't know me, and I'm Herman Johal, and I'm at MacOrtho Trauma and one of the trauma surgeons at Hamilton General Hospital. I have no real disclosures other than, this topic is very near and dear to my heart. I am somewhat, for some reason, trying to stumble through a PhD thesis on value in ortho, and this central to this concept is outcomes and recovery and trajectory. And, to help keep my own bias out of it, I'm actually excited to welcome Dr. Prism Schneider as one of our co-moderators, and she'll kind of help the discussion and keep it flowing. And I'll be watching the chat to get everybody involved. And at this point, I just want to see, has Prism been able to sign on? Is she joining us yet?
I am, Herman. Thanks so much for having me.
Right. Well, I'm, on that, I'm just going to say I'm really excited to have you join us, Prism. And I call her a colleague, but really a friend who's near and dear to my heart. We're co-residents at the University of Calgary. We just went through the CARMS process. We went through the CARMS process together that we just concluded again this year. And I think everybody had a really successful match, and those brought back memories of our own CARMS experience. And Prism's, she's a doctor, PhD, ortho trauma. She just did a trauma fellowship at Houston, and an additional fellowship in McGill, and she's really one of the hearts of COTS. And I would say I'm really honored to co-moderate with her tonight. So I just want to at this point turn it over to Prism to give a brief introduction of all of our panelists, and I'll sort of run the slides if she's happy enough to talk us through tonight's evening.
Fantastic. Well, thank you so much for the invitation. I'm really excited to be here, and what a fantastic panel of speakers that we have tonight. So very excited to begin with Dr. Rick Buckley, who I have the pleasure of working with here at the Foothills Medical Center in Calgary. And he'll be speaking to us about managing patient expectations, lessons learned. Dr. Buckley is known to, I would say, everyone. He is a professor here at the University of Calgary and certainly has a wealth of experience through COTS and through the AO as well. So very much looking forward to your talk, Dr. Buckley.
And just going to go to the rest of the speakers as well.
Perfect. So Dr. David Ring, I'm really excited to have Dr. Ring here. On a personal note, I was able to travel to visit Dr. Ring when I was a fourth year resident, and just an invaluable experience, particularly in this area about patient reported outcomes and interacting with patients. So extremely happy to have Dr. Ring joining us here from the University of Texas in Austin. Dr. Ernest Kwek. Very excited to see you, Ernest. We also know each other from ages and ages ago, so thank you so much for being on the panel today. Currently the Chief of Orthopedics in Singapore, and boy, do I ever look forward to traveling to see you someday soon. Last but certainly not least is Dr. Kelly Lefaivre from UBC, an associate professor and also very well known for contributions through COTS and Canadian and I would say worldwide contribution to orthopedic research. So very excited to have Dr. Lefaivre joining us tonight as well.
Right on. So with that, let's turn it over to Dr. Buckley for the first talk, and we'll give him the ability to share his screen there. So I'm just going to stop and turn it over to Dr. Buckley.
Thanks, Herman. See if we can get this up here. Can you see that now?
Yeah, it's coming through there.
Good. Okay, so I'm going to rattle through just like Herman had asked to try to be done here in 10 minutes. Managing patient expectations and hopefully some directions, because we've sure had a pile of barriers. Change, it's a short trip from riding the waves of change to being torn apart by the jaws of defeat. Well, I'll tell you that I think, and part of my objectives are to try to show you why we've done so poorly with our topic here. I'm going to talk a little bit about historical patient expectations, discuss some research behind present patient expectations, open the dialogue for self-efficacy and resiliency, and then how can COTS close this expectation gap? Because we've got a whole new young generation coming along, and I know they're up for it. So here we are, Civil War, 1860s. How was their outcome? Well, you know, they'd strap on their leg and they'd go and they'd chop the wood and they'd go shuck the corn and they'd do whatever else they had to. And there wasn't many complaints because there wasn't much else. And, you know, the past for patients and their injuries. Here we are in the early 1900s. Any doctor was revered and respected. And here we've got Dr. Alby's fibrous arthroplasty. And it was for a high femoral neck fracture in 1918. And of course, all patients got a great result based on his paper because I've got it in my library. Care was paternalistic, little was told to the patient, and there was no questioning about results. Now here's the cast brace of Vern Mooney in the 1970s. Well, how marvelous was that? Wow, no more traction, no need to hang in place for weeks in bed for a distal femoral fracture. This was during the Vietnam War, and it was the latest. And I mean, who wouldn't be happy when you can get a traction? You don't need to have any other type of treatment. But here we are now with something completely different. And this is one of our residents who's now staff out on the coast. And here we are, 2021. We got all kinds of different types of AI and AR happening, and it's extremely exciting because it's different. And so, you know, our research in the early 90s was one where we just were taking little tiny baby steps. Our steps were so slow. And when we started with COTS, our outcome measures, we all began, you know, what are we going to do? So Ross Layton, myself, Bob Meek, Bob McCormick, Dave Petrie, we kind of said, you know, we should have patients fill out forms. They shouldn't be surgeon thoughts. Were they validated? Well, not really. Were they useful? We thought so. And so, geez, we hung our hat on the SF-36. The Harris hip score had been used for years. We didn't use it, of course, in our early studies because we didn't really have any hip studies. But we were really concentrating way back in the early 90s on not surgeons' opinion or thoughts, but the patients. And so we'd made a difference, we think, with starting out COTS with patient outcomes. This book from 1996 was an interesting one because it really opened the door talking about patient outcomes, how diverse they were and difficult to predict, multifactorial. Bessel A. Vanderkolk wrote all about types of trauma, social situations, personal situations, and how different things were in war and national disasters as far as traumatic stress. Now, our calc study came out in 2002, and we were very happy to have only patient-related outcomes. They were the best that we had at the time. The LEAP study also came out in 2002, the first report of it, and they used the SIP, the sickness impact profile. And it showed that, for example, with an AMP or a reconstruction of a badly injured limb, that the end result was about the same, and it was the same for return to work. So this was at 2 years, and I found this to be really a study, despite the fact that it couldn't be a prospective randomized trial, really opening the door for patient outcomes. Now, this book by Suk, which is an AO published book, I was a chapter editor for, and it was the first book I know about where we talked about MSK outcomes and measurement tools and instruments. And so in 2004, it came out and it described all the different outcome measures for all the different body parts. And importantly, at that time, some body parts had no measurements, no particular outcomes. And so this was the beginning of injury specificity. And I had myself written the chapter on calcaneal outcomes because there really were none other than what we had used for our calcaneal study. 2005, the LEAP study comes out with longer results, longer term. And so at 7 years now, using patient-related outcomes, both groups worsened. And you could see the beginnings of, okay, where do we have to go? Where do we have to look at? Because when you had a high sickness impact profile, you got a bad outcome. Rehospitalization, low education levels, smoking, poverty, no health insurance, litigation, poor social supports, and importantly, what now is grouped as the social determinants of health. Poor self-efficacy meant a poor result. And so it behooves us to get to know our patients when it comes to outcome. Are you going to have somebody on the left or somebody on the right? Because is this somebody who you can't put a mountain high enough they won't climb, or somebody who really has a hard time getting up in the morning? And really, it's so different, whether it's work, play, the expectations that person has, the lifestyle they hope to live, culturally, financially. This self-efficacy is so important, and it was hinted upon by Ellen McKenzie back in her LEAP study in the JBJS. Patient satisfaction determined by how they function, the pain they've got, and then a little bit about depression. So here's my own example, a 17-year-old patient of mine from about 5 years ago now, and she's only injured her one lower limb in a boat prop injury. And so it ended up being removed. But it was a good choice. And here she is as a para-Olympian down in Rio 1 year later. Pretty unbelievable. But it all has to do with a person's self-efficacy. Now, this publication of the British Medical Journal in 2009 looked at measuring patients' experiences and outcomes. And unbelievably, its opening statement there, underlined in red, there is now a widespread realization that patients' views are not optional, but essential to achieving high quality care. Well, here we are now, just a matter of 12 years from where we sit now in 2021. And we're even having to start a statement of a major publication like that. In that same year, Auerbach in the core came out with healthcare quality measurement in orthopedic surgery. And he broke it into 3 different types. The structures of care, which really had to do with how you presented your resources to the patient. For example, at the very bottom there where it says examples under number 1, presence of a dedicated arthroplasty team if you're doing arthroplasty research. The volumes of the surgeon at that hospital, presence of an arthroplasty care pathway, or 2, the processes of care. And here it had to do with, things like, did you provide antibiotics, the type of implant used, and then lastly, number 3, the outcomes of the patient. And you can look at the patient health status, functional status, their satisfaction, mortality cost, all different types of things, range of motion, things that, anyway, when you look at it with outcome research in this way, it's thought to be really organized and thorough. Well, in 2013, myself and Suk got together again, and we put together TEF-TOM, a promising general trauma outcome measure. And this validation study came up with TEF, trauma expectation factor. So you'd ask a patient in today, 2021, 1 year now, what do you think in 1 year, how painful do you expect your surgery to be? How painful do you expect your result to be? And then TOM, trauma outcome, at that 1 year, so in 2022, you'd say, well, how painful are you now that 1 year has passed? And this became known as TEF-TOM. And if I can explain it now, here we have number 1. This is the patient's in at 100%, falls, break both heel bones, just like you'll see in the top right there. So they slip all the way down to that bottom yellow line. So say the injury was 2 years ago in 2019, and they start creeping up that yellow line. And you say to them, well, geez, how do you think you're going to be? Well, the trauma expectation factor and then TEF-TOM, their outcome measure, is the gap. It's that gap where they hope to be, but they're never going to make. And of course, this is one of the problems with trauma, is that we can never make patients perfect again, but that expectation factor is crucial. And then we published on that in 2017 using TEF-TOM, comparing patients from Calgary, New York, and Brazil with an ankle fracture outcome based on how these ankle fractures did in those 3 locations. And we looked at socioeconomics, type of fracture, education, geographical location, and we found that you could not please a New York patient. Impossible. They had the highest expectations, and we never met their expectations with what they wanted out of their broken ankle. Brazil, they were just happy to get surgery, and so all of their expectations were met. Interesting, if you had lower socioeconomic groups, the smokers, they had lower expectations and were happier. People did recognize that if they had a bad injury and you told them from the beginning that they would have less expectations and they would expect a lower result. And education level, if it was higher, they had much higher expectations, which then opens up self-efficacy again. And here, JBJS Current Concepts Review just from last month. Resilience in the orthopedic trauma patient has taken us this long to get there. It's demonstrated that resilience may contribute to favorable mental health and physical function after a surgical procedure. Well, I'll be darned. Lo and behold, we're finally there. Unbelievable that we can finally even start to talk about it. And then they say orthopedists should consider resilience assessments in trauma patients. Well, I don't know why our orthopedic world hasn't done this. We've been so far behind. It seems very obvious why we're the last polar bear on this little ice cap, and why we can't help patients who lose both legs get back to run and help them with their expectations. So an example, world record for sprinting, 100 meters, 9.59. But you know, if you lose your leg, it's pretty good, 11.33. So how come we've not developed self-efficacy measures that will help predict for someone who loses a leg how they're going to do? We really need to do this. And so here at the bottom right, motor, the MacOrtho group, we've got COTS. And you know, Mac is great at producing ortho evidence. Here's the latest one from April 5th, just this month, 2 weeks ago, all about arthroplasties and another systematic review. Well, you know, COTS and Mac are good at creating evidence, but we're way behind in the area of expectations. We need to take giant steps forward, and we really need to do it. I'm finishing here now with a couple videos. Here's a patient of mine, again, another prop injury from a boat, and you'll think nobody in Calgary can be able to ride a boat or get out of a boat and be safe. Well, on your left is this patient now standing up for the first time, and he had both legs injured. He lost one leg in the boat prop, and the other leg we reconstructed. And this video is worth watching just to see his smile when he finally recognizes that he just stood up for the first time. And there he is, just stood up. And then here he is at 3 months. And he's just walking at home now for the first time, 3 months after injury. Okay, so it's somebody like this who's got this attitude, you can see, who, guess what? We have something small like a 5-kilometer run. Well, you know, he ran 5K at 11 months because he had good resiliency and family supports. And here he is finishing his 5K. So orthotrauma has so far to go. We have to get to know our patients. They need to get to know their disease. Trauma is tricky, and other patients can help to talk to them through their tough times sometimes, especially with something like an amp. But my goodness, change is the essence of life. Be willing to surrender what we are for what you could become. We have to be way better. We have to change our attitudes, COTS, and our direction in relation to patient outcomes, because expectations have changed from the past to where we are today. Presently, expectations are very different. And we should be talking about self-efficacy and resiliency. And COTS must close this gap by simply doing some good prospective research and working together with this. So there's a challenge ahead, but you know, it's too important to ignore. Thanks very much.
right, that was great, Rick. I think we'll save the discussions for the end. I think that brings up, but it's a great introduction for Dr. Ring to carry it on. So with that, I'll turn it over to Professor Ring.
Yeah, I love the topic. Obviously, it's kind of what you stumble on if you do any research or practice for any amount of time. And I'll just pick it up from the not everybody does as well as you hope they will do. And some people do better than you ever expected them to do. And let's see if we can figure out why that is. The first thing is that not everything is as it seems, and that's just the way the human mind works. This is codified in the Nobel Prize winning work of Kahneman and Tversky, and they basically invented the concept of cognitive bias, that your mind is a guessing machine, and that is very powerful, an amazing guesser, but not perfect. And that's why you also have an analytical or critical approach. So it's because at times you think that middle line is longer and you measure it and it's not. And there are many named cognitive biases. These shortcuts, again, they are useful and they are highly accurate, but not completely accurate. And they are a source of a lot of misconceptions. When we talk about people doing less well than expected, sometimes they do markedly less well, like this is as much of a fist that can be closed long after the external fixator wounds are healed on this operatively treated distal radius fracture. Skin's a little shiny, so we talk about what this might be, and you can actually relate this to cognitive errors. Here's a list of cognitive errors that result from cognitive biases. For instance, your mind is evolved to interpret hurt as harm. And if it gets stuck on that, then you will avoid making a fist when you're trying to recover from a broken wrist. Now, these thoughts end up being pretty sticky. That we put together this idea of a set of cognitive errors that were common in the office. Negative pain thoughts questionnaire, we called it. We recently published this study showing that the more symptoms of depression you have, and those are the lines going up the graph, the more the pain intensity increases based in relation to negative pain thoughts. So in other words, and here's another version of that comes from some data from Oxford. My colleague, PJ Jayakumar, did his PhD thesis on about 800 patients recovering from upper extremity fractures and categorized them as mild, low, medium, severe. So low would be like a metacarpal fracture, and severe would be an open bicolumnar distal humerus fracture. And you can see that as the symptoms of depression get higher, a metacarpal fracture can have the same impact on symptoms and limitations, or DASH, as a more substantial fracture. And then the same is true for misconceptions or misinterpretation of symptoms. The effect of that, if you have a lot of misinterpretation of symptoms, it makes the mild and the severe injuries have the same impact in terms of how you feel and what you can do. So a lot of this comes from a talk that Diego Fernandez, a slide of Diego Fernandez's, and it came from the point in his talk where he talked about complex regional pain syndrome. And a psychologist I encountered years ago pointed out to me that the criteria for these, and you can choose your criteria, are internally inconsistent. Because if you look at all the things that happen 1, 2, 3, and then you look at 4, excluded by the existence of conditions that would otherwise account for the degree of pain dysfunction. So if you break your wrist and then don't move, you get 1, 2, and 3. So there's always another explanation. There's always another explanation. So these criteria never apply. And what does apply is, again, misconceptions or misinterpretation of symptoms, which are reinforced by worry and despair, by symptoms of worry and despair. We're going to get out of trauma for a bit, just because I think this study really makes the case in population data. Population-based data is different. It's not the people coming to see us or coming in with an injury. It's the people who have a disease, whether they see you or not. So population-based data is hard to get and very useful. And this is 660 people in Korea. And what you learn from population-based data is if you look at, these are the KL grades of knee arthritis, and it's hard to read, but the numbers at the bottom, if you look about 5 out of 6 people over age 65 have knee arthritis. In other words, get ready for your knee arthritis. I wish it on all of you, because if you live long enough, you will get it. And then on the y-axis is whether you have some sufficient symptoms and limitations from that arthritis to qualify as having a diagnosis of symptomatic knee arthritis. Now look at the people who have KL4, which is severe. It's not just no joint surface and bad osteophytes, it's actually deformity in the knee. And less than half of those people qualified as having knee arthritis. There's your resiliency, and which is basically accommodation and adaptation. Now, if you look at people that have 0, no radiographic arthritis, or 1, minimal, there's people there, about 7% of them qualifying as having symptomatic knee arthritis. So those are the people that you're puzzled why they're doing so poorly. You can't make sense of it because the x-ray doesn't show anything. And then if you put the two together, and again, unfortunately, they dichotomized everything, but it would be better to see on the continuum. But they dichotomized depression, and they dichotomized knee arthritis. And depression had as much influence, 6 times greater if you had met that threshold depression level as if you met the criteria for severe osteoarthritis. So they're both having a major impact. And this is the mind-body connection seen in population-based data. And it's interesting that when you get to the higher grades, the symptoms of worry and despair and misconceptions probably have less impact. It's at the moderate grades where they're having the most impact, kind of about where somebody realizes, oh, I've got a knee problem coming on. And then as Rick pointed out, it's time to evolve your identity. It's time to change the way you consider yourself healthy. If you do that, you succeed and you're fine. That's what the people who are in the KL4 who don't have symptomatic knee arthritis did. They said, well, now I'm an older person with a knee that has a varus thrust and looks funny and hurts every time I step. That's okay. I'm healthy. The better you can do that, the healthier you are. Thank you.
That was fantastic, Dr. Ng. Thank you so much. We'll move on to Dr. Ernest Kwek, who's going to speak to us about challenges in managing patient expectations, specifically with the Singapore perspective. So thank you very much, Ernest.
Thanks, Prism. And I'd like to thank MacOrtho and Herman as well for the invitation to talk here. I think most of us have been experiencing COVID in the past year, and most of us, especially in Singapore, have been made tourists in our own countries. And so it makes sense for me to just offer up a local perspective from Singapore on this topic. I've got nothing to declare. And so if you've not been to Singapore before, it's a sovereign island city-state smack in the middle of Southeast Asia, surrounded by Malaysia and Indonesia. We've been independent since 1965, and in a short about 50, 60 years, we've grown to a population size of 5.8 million in a space that is slightly just larger than the city of Calgary. So that gives us the second highest population density in the world. In terms of the healthcare system, we have been ranked among the best in the world, and in a Bloomberg study in 2020, we've been #1 on their healthcare efficiency index. We are the healthiest country in Asia and 8th in the world. And in Lancet study in 2017, we also had the longest life expectancy anywhere in the world, about 84.8 years since birth. But if you've been to Singapore, you know how shiny it is because it's clean. But the question is there anything else that's happening underneath that shiny surface? Has that rate of progress and advancement actually resulted in problems for us here in healthcare? And I'll go through these from my perspective. So most of you may know Singapore prides itself in being multicultural, and this stems from its history as a trading shipping hub in the middle of the Straits of Malacca. And that really brought in a lot of migrants from many years ago, resulting in this multicultural society that we have. The majority of us are Chinese. We do have 4 official languages, depending on which racial group you come from. So we have English, Mandarin, Malay, and Tamil. And of course, a local version that's known as Singlish. That's my version of English. I'm trying not to speak that here now. But the language problem in itself is something that I feel is a major barrier to patient expectations and outcomes. And this is why, because many years ago, we faced a healthcare shortage in terms of manpower, especially in nursing. We found that with the rapid progress, most locals were not looking for jobs in healthcare, especially in nursing, where they weren't paid the best. And so we reached out to our neighboring countries, our non-traditional sources, and brought in lots of nurses from neighboring countries like Philippines, Sri Lanka, and Myanmar. And that in itself created a lot of problems in terms of the ability for us to speak to some of our patients and communicate in a language that they understand. There are also problems in our demographics, inherent in our demographics, because of the population squeezed into this 236 kilometers of land. We find that there are many generations of patients stuck together, some living under the same roof. And the older generation, because of the fact that we've only been developing in the last couple of years, the older generation, anyone above 60 and 60 years of age, are still, suffering from poor education. They have no understanding of English, and sometimes even not the mother tongues as well. And they have only a grasp of multiple dialects that no one else in Singapore really understands. Plus, you top it up with the traditional Asian value of filial piety. And that means that the families really have to take care of each other. And I myself, for instance, I'm living with my mom and my children. And so we have 3 generations living under some roofs. And that means that decision making isn't something that's made by the individual necessarily. And we have this concept known as a kampong. That's a Malay word for village. And that really means that whenever something happens to a family member, the whole kampong, the whole family has to get involved in the care decisions for that patient. That in itself lends itself to a lot of difficulties and challenges that we face. In terms of the education system, it's also one of the top education systems in the world. We have a mandatory primary school education for all our citizens. In the past few years, we've also placed a very large emphasis, a very strong emphasis on developing our digital infrastructure. So now we have the most tech-savvy country in the world, the highest internet speeds, internet penetrations to 88%. My mom, for instance, is always on her iPad. And so what does that mean for us? It means that our patients have a very rapid and easy access to information that not necessarily pertains to their care. Dr. Google, for instance, is one of the most biggest barriers that we have in terms of relating proper care decisions to our patients. We also have a public-private system going on in Singapore. So there are about 9 public hospitals that all within that small space provide tertiary level of care, all treating trauma within 20 minutes of each other. And that's because of our government's promise for easy access to good healthcare to all our citizens. At the same time, we have private hospitals, almost the same number of private hospitals providing care for some of these patients as well. And so this means that a patient can actually get admitted to one hospital, discharge themselves, go to the other end of Singapore and seek help for the same problem there. Similarly, it also means that you have patients who may present themselves to a private hospital, get an opinion, get sticker shock from the fact that the private hospital bill costs about 10 times that in a public hospital, and then present themselves back in a public hospital for any complications that may arise. That then, of course, presents a problem with expectations, especially if you have complications that arise and patients may then seek various opinions from various doctors. In Singapore, our healthcare financing is pretty complex. The government provides subsidies, up to 80% of subsidies for all our citizens. On top of that, if you still have the need for more funds, you can draw on your own MediSave funds, which is mandatory savings that's set up by the government. You have mandatory insurance schemes that you can tap on. And finally, if you are really needy, you have a MediFund that's also possible to use. That unfortunately creates a lot of complications in terms of patients' understanding of how to finance their bills. And a lot of times, instead of asking questions like, what's my prognosis? How am I going to get treatment? They tend to get tied up in thoughts about how we're going to finance that bill. The other problem is that we find that this is probably just a very Singaporean thing. Even if you're paying 20% of that bill and 80% is subsidized, there's a feeling of entitlement that you have to get the best care possible. And the other end of the spectrum is true as well. If you're paying all of your bills, then you absolutely demand that the best care is provided to you. And some of my best work on patients, for instance, have left the hospital dissatisfied because they had complaints of the food or the air conditioning in the hospital. And so that amount of dissatisfaction and trust does translate to what we see on the ground here. About 18% of patients or Singaporeans have disagreements with treatment plans that are prescribed to them. About 30% have no understanding of what is being done to them at all. And if you look on the left side, 80% of patients trust their GPs more than the 60% that trust their specialists. And somewhere in between is the families and friends that they value their opinions more than the specialists that are treating them. There are some vulnerable populations that I also like to point out. In Singapore, our prevalence for physically and socially frail patients are amongst the highest in the world, about 5.7% of our population, with a global average compared to that is 4.3%. And expectation here, again, is because of the Asian values that we're talking about, is that you should be taken care of by your family as you age. And so throw self-efficacy out the window, throw resilience out the window. These patients are here for the long run, right? And when you look at the flip side, the patients don't have large families to support them anymore. Their children are all at work because of the need to keep up our population's GDP. And so they bring in foreign domestic workers from the region to help manage their parents. And there's also a big crunch situation that's starting to develop in a long-term facilities like a nursing homes. And the norm really, even after if you had surgery that made, and given the ability to even fluid bear after surgery, is to expect at least a month or two of recuperation in a rehab facilities. And we aren't building them fast enough to keep up with that. Senile dementia is also one of the biggest problems that we're facing, especially in our elderly population. A hip fracture patient that comes in is most likely going to be demented at the same time, or worse yet, has not been diagnosed to have dementia. And so they may have been living at home, taken care of by their families, but the moment they get a fracture and they get admitted, that's the end of the care that can be provided for by the family. We have the highest rates of dementia in the world, about twice that of the global average of 5%. But unfortunately, we rank about 16 out of 30 in terms of dementia innovation. So we aren't keeping up with our ability to treat patients with dementia. And that then leads to difficulties in obtaining consent. So typically a hip fracture patient that comes in, if you find that the patient's demented, we can't get consent from the patient. It's impossible for us to proceed with surgery unless we bring in all the family members for a family conference. And that can sometimes take 1 or 2 days because everyone's working, and that therefore then has a knock-on effect downstream in terms of delays in surgery. And we know what that means in terms of outcomes. Another vulnerable population I'd like to point out is our national servicemen, right? Our country is one of them, a few in the world that have got a conscription army. And so these young gentlemen are citizens who, when they come of age at 18 or 19, are then thrust into the national servicemen, a lot of which are no longer resilient and are unable to cope with the rigors of physical training. And so when they get injured, not only are they not able to cope well with the injuries, their parents who have not gone through a single world war also have a similar expectations that, yeah, you've done a great surgery, but I would rather our patient, my son does not get well. If you could just give him a letter that says that he's not fit for physical training, we'll just get himself downgraded. And miraculously, most of the problems that they face dissolve the moment they finish their training. And so the term king, which is a dialect that we use to describe malingering, is commonly used to describe some of these patients. But the truth is there are major tragedies, right? Because it is a small country, and because of the speed of the social media, the population of the public is pretty intensely, they do fear the possibilities of major injuries happening to their children, and these do occur. And of course, sometimes because of the speed or quality of initial response, that the outcomes of treatment here may not be the most optimized. The last population that I feel we should highlight are the migrant workers that Singapore has a heavy reliance on. Again, because of the rate of progress, nobody wants to take out construction work as a career option. And so we've been bringing in migrant workers, up to 1 million now from the region. These are unskilled laborers, poor grasp of language, can't speak English well. And again, we have the problems of communicating to them. Plus, because of that, the safety awareness is poor, and they are very highly prone to getting injuries as well. On top of that, you think that workers' compensation injuries are bad enough. The Singapore situation is even worse. We have errant companies who don't respect the accident insurance requirements and send these patients packing off without surgery, or even shortly after surgery back home. We have delinquent doctors who engage in agreements with some of these companies so that they don't report these injuries and they don't get their compensation. And therefore, there are legal lawyers who prey on such situations and encourage patients not to get better so that they can get a windfall in terms of compensation and bring that home to their countries. Of course, patients who don't understand this because don't understand their basic rights are part of this problem as well. So to end off, I think that it's important for us to still, recognize that there is a gap here. And in Singapore, that gap is probably a little bit wider than in some other countries. And the major barriers that we feel contribute to this in terms of language, dementia, in terms of the need to engage the entire kampong for decision-making rather than just to deal with the patient as him or herself, are contributed by some of our cultural or geopolitical impediments. And also to recognize that there are vulnerable populations who have an inherent difficulty in overcoming some of their injuries, whether this is real or not. And in overcoming these challenges, I've personally realized that really providing person-centric care in Singapore is not just for the patient. You have to involve the rest of the family in any decision-making, so that shared decision-making requires a lot of patience and empathy on the doctors or the surgeons side. And it really requires a mindset change. Expect a lot of delays in your surgeries, expect a lot of delays in decisions, lots of conversations with the family. And, with COVID, we've at least managed to overcome that with some of the telecommunications that we've set up. But at the same time, realizing that outcomes are, in this case, usually multifactorial, and they don't always reflect the quality of our surgical care. So thanks for listening to my rant.
Oh, thank you, Ernest, for sharing your thoughts and your experience and your perspective. I think that gives us a lot to think about, certainly, especially as well as the other two talks, and how we think of what yardstick do we use to look at all of these different populations, and how are we going to incorporate that into research. And I think with that, I would love to get Dr. Kelly Lefaivre's perspective on things, and look at a challenging fracture and a challenging outcome set to measure. So I'm looking forward to hearing her thoughts as well. Take it away, Kelly.
Hey. Unmute. Okay, perfect. So thanks for the invitation, and thanks for your attention for the next few minutes as we talk about one of my favorite topics, which is outcomes after pelvic fracture and how we measure them. Whoops, I never understood that beep on Zoom. So I have a few disclosures, none of which pertain directly to what I'll be talking about today. So I'll start with the case. This is a 50-odd-year-old patient that was involved in a very high energy injury on a motorcycle that I treated about 3 years ago. And I think we can all appreciate, based on this X-ray and this three-dimensional CT, that this patient has suffered a life-altering injury. We can see he has a complete dislocation of the hemipelvis at L5-S1 and quite a profound injury in the anterior ring. So what we're going to try and get at today is what are some of the challenges in measuring outcomes in these patients, and what are some of the bigger picture things we should be focusing on. I'd like to really hit just kind of four main things at a high level. So radiographic outcomes, although historically we love them, what are the issues with those and why they don't work here? functional outcomes and how we use them, what some of the strengths of general functional outcomes and disease-specific functional outcomes are in this group. Next, I want to touch on that idea of trajectory. I heard mentioned at the start of this session. I love that term as it relates to patient outcomes. So how we're going to track how these people do over time. And then finally, just a few final words on sexual and urinary function, which is sort of a unique issue that these patients face. So we know as orthopedic surgeons, we love x-rays. It's something that we think we can control in the OR, and it's something that historically has played a really prominent role in the literature. So we did a systematic review looking at how x-rays have been used in the pelvic fracture literature, and this was published in 2012. So what we found is the overwhelming majority of the time, authors use x-rays, and they use plain x-rays the vast majority of the time. But what really stuck out is that the overwhelming majority of the time, authors don't tell you what they're measuring. So they report an outcome, but you aren't really left with the tools to reproduce the measurement technique they used on what's a really complex three-dimensional structure. Despite that lack of standardization, authors love the Matta and Tornetta scale, which was published in the late 80s and is essentially an expert-driven scale where there's been a decision that 4 millimeters excellent, 5 millimeters good, and so on, that there's these kind of discrete cutoffs related to displacement. So despite kind of the rigor of the radiographic outcomes being low, authors in general are really favorable about their own outcomes. So 80% of the time, almost good or excellent outcomes were reported historically. So we came away from this kind of wondering, well, if everyone thinks it's so important to within the millimeter, can you actually measure that? So we haven't established whether it matters. What we want to establish first is, can you even measure it? So we took the radiographic methods that we found in that systematic review and had a panel of experts measured standardized x-rays using 3 different specified techniques. And essentially what we found is what's historically been reported is not something we can reliably measure. So we can't reliably measure absolute displacement to within the millimeter, and overall impression has a really poor reproducibility. Simple measurement techniques with really specific instructions, like the cross measurement technique you can see above, we can measure that pretty closely, pretty good reliability with that, but that doesn't give us a result that's directly interpretable based on how we typically talk about pelvic fractures. Patient-reported outcomes have taken an increasingly predominant role in the pelvic fracture literature. And in this systematic review published in 2013, we found that general measures are used fairly frequently, and most commonly the SF-36, followed by the SMFA. There are several disease-specific measures published for the pelvis. And at the time of this systematic review, the most commonly used was the McGee pelvic score, followed by the Iowa pelvic score, and then the Orlando pelvic score was used only by Cole, who was the author who wrote it. We wanted to know how these pelvic scores behaved in relation both to each other and to general functional outcome measures. So we called back a group of patients who were fairly long removed from injury. So they were a mean of 5 years from injury, but at least a year post-injury. So we had them fill out all 3 of those scores, and the SF-36 and the SMFA as well. And what we found is those disease-specific scores, as you would expect, correlate really closely with the physical composite score of the SF-36. So the physical measurement component of the SF-36, they measure all really closely, but they don't capture anything that's very similar to what's in the mental composite score of the SF-36. So they're all primarily focused on physical aspects. There was no specific patient preferences, so literally a third when patients were asked which of the scores they thought measured their function best. What was most telling, though, were what's on the next 2 slides, which was first that all of those pelvic scores, although we think that a disease-specific score is going to be better in this disease-specific population, they're all plagued by significant ceiling effect. So once you get to a certain level, once you improve to a certain level, the scores lose their ability to detect change, which can be a common problem. And finally, we asked these patients what actually mattered to them. So what were the biggest issues they had in the long term? And you can see at the top, yes, recreation and mobility, which relates to physical function, was a common finding, but all of these other components don't relate directly to physical function. So emotional strain, employment, financial strain, anxiety, and sexual function. Moving now to this concept of trajectory. So we know these patients are significantly injured. We know there's challenges in measuring their outcome, but what can we tell patients, or what can we expect as far as the length of their recovery? And equally important is, how do we plan research? So what is the end point of treatment? Is it 3 months? Is it 6 months? Is it a year? And so on. And historically, these things have been fairly arbitrary. So we had a cohort that we've been recruiting into longitudinal study for many years. We presented this on the podium at the OTA in 2017. We had 108 patients with complete data, about 70% men and about 70% B-type, and these were all surgically treated pelvic fractures. And so looking at the SF-36 physical composite score, we can see that patients have an abrupt drop-off in function at the time of injury, which is what you would expect. Then they have a fairly steep improvement between 6 months and a year, but that there's tons of clinical and score-based activity happening beyond a year in this patient population. And looking at it from a different angle, which is the proportion of patients that are having clinically relevant change, so that are meeting that threshold of MCID, we can see that a huge number of patients are having clinical change between each of those time points. And probably most importantly, that more than half, or 60%, are having clinical change beyond a year. B types do slightly better than C types, but neither, as has been pointed out by Dr. Buckley, are anywhere near where they started at baseline. So this is an injury that truly brings with it significant long-term disability. Touching now for a moment on sexual and urinary function. So because of the anatomic location, this is a frequent issue in pelvic fracture patients. So about 6 years ago, we added this component of the ICIQ questionnaire, looking specifically at urinary and sexual function, into our longitudinal data collection in pelvic fractures. And so this was the same cohort, but slightly broader, because we reported this a few years later. And so again, mostly men and over 70% B-type fractures, and information collected at baseline, 6 months, 1 year, and 5 years post-injury. So if we accept that lower scores are better and higher scores are worse as they relate to urinary function, we can see that both men and women have a significant decline in urinary function that is not only present at every time point, but appears to worsen over time. The other component, the sexual function component, again, a substantial impact in both men and in women. And the overall trajectory is that sexual function doesn't improve in the same way that physical function does. Regression analysis shows that there was some prediction by fracture type, treatment category, and symptoms at presentation. But to me, the real takeaway from that study is that sexual and urinary function is common in this patient population. And when it's present, it's persistent. So that when it's detected or when it's diagnosed, there is value in early involvement of multidisciplinary care. So stopping off on a less sunny note, as we'll come back to my patient from the start. So this was the third operation we did on this patient. He was initially treated with fairly standardized techniques and went on to get a non-union of the sacrum. This was a revision procedure we did in combination with the spine service, where he had a technically successful L5-S1 fusion. But this patient had terrible PTSD, he had significant chronic pain issues, he had other life stressors, and unfortunately, about 1.5 years after this procedure, succumbed to his second suicide attempt. So the takeaways are that radiographic outcomes really have unknown impact on function and are not reproducible really in this population. SF36 is responsive in this population and captures a broad range of impacts. And there is issues with the previously described disease specific measures. The trajectory of recovery in these patients is long, but at the end is incomplete, and they do have long-term disability, and that sexual and urinary function is common and doesn't have that same trajectory of persistent improvement, so should be intervened on early. Thank you.
That was fantastic, Kelly. Thank you so much for such a kind of historic and complete picture of, some of the pitfalls and challenges ahead, but the work that you and your group have done in this area. So thank you. So at this point, we're really happy to open the floor to discussion. We'd love to stimulate some questions either through the chat, or you can turn your microphone on and go ahead and ask questions. We do recognize that some of you may need to leave, but we'll certainly stick around for those who have questions. So maybe I'll start, and then we'd love to stimulate some discussion. I think we've really touched on in multiple talks this discrepancy in patient recovery as more of a patient experience versus these outcome measurements and what we can objectively assess per se. And so, if we think about one, for example, as return to work, so that's sort of a time to return to work that we can report as a measurement. However, just as an example, very fraught with things like, well, job satisfaction. Does a patient even want to return to their current mode of employment? So just as an example, how can we try to strategize reconciling patient experience with recovery and objective measurements?
Well, I can try there, Prism. That's so tough. And you encounter so many challenges as soon as you bring work in. But it really, again, comes down to self-efficacy, because people who are really resilient, they want to get back to work. They want to get back to their normal life. They want to have things back the way they used to be. And it's interesting. I know myself, having been involved with the workers' comp for years and years, and then followed some of the research out of the workers' comp. In one study that was done looking at just workers' compensation board papers, something like 29 out of 30 papers showed that patients did less well than the regular public. And that just shows as soon as you've got a reason to be sick, you're getting paid to be sick, you've got issues. So the work brings in a huge amount of problems. But again, I think it comes down to if we could develop some form of a self-efficacy score, a resiliency score that took into account the patient's personality, what they respected in life, their family supports, and could apply it. Now, you'd hate to get a score that, geez, I only got 2 out of 10. I mustn't be very resilient. But it would help you predict for them versus other people who score 10 out of 10, and you're not going to be able to keep them off the rugby pitch. And so this is where we're still stuck. We're no better 35 years since I started my practice.
I would be careful, Prism, calling it an objective measure for the reasons Rick mentioned. So I got upset about this because a lot of studies, the only difference you can show is in return to work. So the scaphoid fracture is one of them. And it's a foregone conclusion. It's about what type of work you do. So I'm also a hand surgeon. So we did carpal tunnel, which is similar. And the two things that determined it, there was 2 categories. One was, are you a laborer or a desk worker? That's it. I mean, that makes sense. And then the other one was all the misconceptions and symptoms of despair. And so grip strength is similar. They're not objective. They're not objective measures. They're objective measures are radiographic measurements, and even those have measurement error. But there's return to work is not objective.
And I actually oh, sorry.
Sorry. What I was just going to jump in and say is this is my favorite topic because I do think it's so interesting. But the difficulty in my mind is not so much in the evaluation piece, because there are scores that have been developed to evaluate resiliency and self-efficacy. But it's more on the intervention side. So you identify that someone has poor resilience or poor self-efficacy. So then what is the intervention? So I feel like most of us with a fair amount of experience feel like we can identify those things even without a questionnaire. But it's the intervention piece that to me it is the big block. You know, that's where the real breakthrough could be. Anyone have anything to add on how they intervene or ongoing research on intervention?
Well, I think just to kind of jump in with the question from the chat, I think applies is from Steve, and I think this is great to hear Kelly's thoughts on pelvic fractures. Is how has what you learned about pelvic fractures and what's important changed about your interventions and how you do surgery? Like, and knowing the radiographic outcomes are hard to measure and how to compare, it may not matter. Like, what are you aiming for now and how do you intervene?
So, I mean, am I black there? Can you see me?
Oh, sorry, I thought maybe you had your video off for whatever reason.
No, I have I was on a different camera, but it was blocking my real camera and it wasn't working apparently. So it doesn't change because that's still the piece that we can control. So when we're in the OR, we can't control what the patient's degree of injury is or what their home support is like or all of those other pieces. But at the same time, I give it its due place. So do I, continue an open case for 12 hours to try to control a millimeter of displacement here or there, knowing what the impact may be on the patient's other risk of complications or infections or other things that may have a more significant impact on their long-term outcome. I try and keep it framed that way. As a piece I can control that I want to do my best with every time, but really in the big picture, it's a small piece.
I would say in terms of what do you do? Pelvis is a good one. If you break your pelvis like that, do you think you're not going to be down? Do you think you're not going to have misconceptions about the future? So we ought to expect it, right? And even if it's just a broken radial head or something, people are going to be a little wondering about whether things are going to be okay and a little bit worried. And they're also going to have misconceptions about what's going on. Like, if I do this stretching exercise, I'm going to make things worse. So I would just say anticipate it and become a better communicator so you can connect with those aspects of it and then guide people towards don't say like, why are you so worried that this is going to be fine? Like, that exercise is good for you. No pain, no gain. Don't say that. That's all the things I used to say. It doesn't work, I promise. But you can guide them more through motivational interviewing and techniques and relationship building techniques to a different way of thinking about it.
Well, I really think it's so interesting to think about this as a group of orthopedic surgeons where, our language is fix the fracture, get it reduced, line it, and these objective measures in PRISM kind of used that term earlier. That's what we're known for, and that's how we communicate. And kind of to incorporate one of the questions from Brad in the chat is, as you kind of uncover these issues that matter so much more than the reduction quality and all of these other things that make a difference, what are the strategies for like intervening with those who have the low resilience? And, as orthopedic surgeons, we can do our part. How does this change your clinic setup, multidisciplinary, all of that stuff? How do we incorporate and give strategies for this? And maybe it'd be great to hear Dr. Ringer, Ernest, any of the other panelists in your own clinic setups, like, is it multidisciplinary? Like, I just finished a fracture clinic today and I was me and some cast techs and a nurse, and there's no psychiatrist or psychologist or that group there. Now we're lucky we do research. We actually have a study going where there's an RCT and we give access to some other supports that are psychiatric services and cognitive behavioral therapy and some of that stuff. But that's not in our clinic, and it's not necessarily at the fingertip of our patients. So what do you guys have maybe in your own setups?
One of the reasons I moved to Austin with a new medical school, Dell Medical School, was because I knew we'd be able to, at least for a while, try some different things. So I actually have a social worker with me in the office. It's a little bit different in the pandemic, but more or less side by side. So if a patient is clearly, if things seem off to me and I'm successful at building a relationship, and I'll get tears, and then the tears become an explanation like, I can't pay the rent, social worker can come help with that. Or I'm 55 years old, I don't speak English and I have no idea what I'm going to do, 8th grade education or something, no idea what I'm going to do when I can't do construction, social worker come in. And if it's just symptoms of depression or really fixed misconceptions like hurt equals harm, they can do a little bit of cognitive behavioral therapy, and they know how to get the person to the psychologist when needed. So I have that luxury. I would tell you, it doesn't solve all your problems because you still have to do your part in creating the relationship and making it something that the patient wants to do. If you just bring the social worker in, It's not going to work. You gotta add, the patient has to ask you for the social worker.
Yeah, I'd agree. And I don't have the solution to this problem as well. And in Singapore, the migrant workers are really a different breed to be dealing with. And so we've crafted a kind of return to work program, especially tailored to these migrant workers. And it's multidisciplinary. You have all the components there. You have an occupational therapist that will do visits to the factories to make sure that they are taken care of there. You've got social workers that take care of their needs. You got psychologists that kind of try to bring up their resilience levels with coaching. And then you have the coordinator who works with the employer of the worker to ensure that they have a place, that they don't cancel their work permits and send them packing home, and that they keep that space for them whilst the medical fraternity works on getting the patient back on their feet.
And if I can add, just think how backwards the world is, or upside down. Because you have the $10 million athlete and they'll have 10 people rustling around them and helping them get better. And just to show up on TV and hit another hockey puck into a goal. Well, when in fact the worker, as Ernest has said, that really needs the effort, or as Dave has said, somebody whose their job depends upon it. You know, we need to have way more education in hospital. We need to have, and really a hospital has been cut back, at least our Canadian system, cut back so that, you know, we move them in and out within days of them getting into hospital thinking we're doing a better job. But, you know, our communication is so bad that they still come back at their first visit and they say, doctor, you operated on my arm, but I don't even know what you did. Or like they look up and they look at the x-rays, like what bone is that? And what is it, like, is this the tibula? Like they have no idea. Okay. And, you know, statements like, you know, oh, thank God I only broke my leg, I didn't fracture it. And you just shake your head, because these are things that we have to spend time with education, and we don't, because patients would get so much better with education. And I tell you, in my experience, guys, if you use that little graph showing, look, this is where you were, this is where you are now. And Kelly showed them, hers were upside down compared to mine. But then they have to get back up to that near 100%, and they can try to climb up there. And you save that in your charts, because they can see, my goodness, my number is better. Because I usually ask them out of 10, you know, how good are you versus the way you used to be down when you were broken.
Well, I think that brings up an interesting thing to think about is, you know, our consent process, like where it's us just like saying a few, like whatever we can, you know, rote memory kind of regurgitate to the patient, get them to sign off on it. Should those charts be part of the consent? Is this something that should be digital? Like, you know, Ernest let us know that there's lots of people getting really tech savvy these days and using iPads. It should consent be something that's more than just us trying to spit as much as we can out to the patient before we hit the OR. Like, you know, some other non-Canadian settings, or like, are you guys incorporating anything to communicate some of these things to the patients, you know, either before surgery or after? Is there kind of, you're following up with them, what their trajectories are and some of these other concepts? Or even the Canadian?
Yeah, well, I do have the you know, opportunity in designing this in the new hospital that we're developing, and it's incorporating some of that technology that we have here in Singapore. So, for instance, if you even have hand out to patients iPads that have all this information whilst they're trying to digest this after you're done with the consent taking process, that helps. We've built in patient information sheets that are specific to the surgery into the consent forms. And I think that's not a new practice, but it's something that patients can bring home and slowly digest and read off. Because the consent process is just, it's too abbreviated for anyone to really digest all that. It's just cognitive overload for most patients.
I think it's really interesting that all of this is stemming around communication. You know, Dr. Ring is saying, speak to your patients about return to work very early. That's a process and it has to be started early. You know, Kelly, speaking about sexual function and urinary function is challenging and difficult. And I promise no one will report it if you just don't ask, right? So it's communication. And now Ernest branching into, you know, digital age and communication tools. I'd be curious if the panel would be willing to share sort of a success line or a way of communicating with their patients that they've found to be very high yield, that people could maybe practice or try out in their centers.
I like that you're noticing that it seems to me all the important discussions in health and how to get and stay healthy end up in communication strategies. And I'll put a plug in for the Center for Health Communication at University of Texas at Austin and Dell Medical School. It's a combination of a medical school and a communication college endeavor. And if you have any conundra, just email me. We'll help you work on. I got all these communication scholars that can help with that. I would say that keep in mind that orthopedic surgeons are the lowest rated in communication of any specialty. And it goes back to what Herman was saying. We're very matter-of-fact thinkers, we're mechanical, get things done. And so don't be ashamed of that. Just recognize that that's your opportunity and work at it. And I would say the summary that I use to keep me, because I am naturally blunt and matter-of-fact and to the point and goal-oriented, that it's for me always my opportunity to be a better communicator. But every time I go in the room, I center myself, because if you're in a busy clinic, you gotta get the stress off of the last patient or whatever. Every time I go in the room, I have this mantra. They say, soothe, not solve. Soothe, not solve. So it's more about the relationship than the medicine. And if you just have to remember that. And when you see somebody kind of mention that they don't like their boss or they have this great trip coming up or they really love to do that, or they like to make dinner for their grandkids, lean into that, get to know that, because when you build the trust, then you can reorient and you can get them to talk about their real needs beyond just their fracture.
I would also, I love that, soothe, not solve. I'm going to use that. I would also add that, this kind of recognition of maybe how little compared to what we were trained we control about the patient outcome via the traditional measures, right? What plate we use, how good a job we do on the reduction, whether they're treated in 12 hours or 24 hours and all of that. And I've also allowed that to allow me to separate the kind of a level of responsibility with the patient's outcome. I didn't make, the patient's social stressors, and depression, and all those other big drivers. The patient may be feeling as though they're blaming me, but, that's because they're frustrated. So you have to meet them where they are, and at all costs, never take it personally, and just be consistent in that, your role is to support them getting better, of which your expertise in orthopedics is part of it. And then facilitating their access to other expertise. But, taking away that 100% kind of at times crushing responsibility, because we don't control so many of those factors.
And I'll just add, I agree with Dave about our communication style. Our College of Physicians and Surgeons here in Alberta has had a terrible track record with orthopedists and their communication complaints. And it's really important that you do simple things like you sit down and you listen to them and you have some empathy. I think I've probably got quite a bit better as I've got older and maybe not quite so rushed. That's something that we just have to spend time and talk, and then we have to listen, because they'll have things to say. Sometimes it's hard to get them to open up, but I tell you, the thing, you wanted a little trick here, Prism, or something that I think is important. I think almost the most important thing is that social history. What is surrounding them? What has them supported, whether it's their job, their wife, their husband, their kids, their family, like Ernest has said. If you don't have all those supports at home, and then what do they want to do? What sports are they going to hope to get back to? And then later on, when they come back, you can mention that, you can talk to them. Just this in and out of fracture care, as we we push them through our clinics, it's just the wrong thing. We just have to slow down and spend some time.
Yeah, I'd like to add that, although as surgeons, we just want to get to surgery and get that over and done with, that mindset change, that we do need to recognize consent taking is a process, and that takes time, and then the patients do need time to digest. Oftentimes in clinics, if the patients kind of look like they're not ready to make a decision, I tend to send them out of the room and encourage them to call as many people as they can and come back with more questions, right? And that really does help them in the process of self-discovery and realization as well.
I want to emphasize that tip because you don't hear it very often. I love that you brought that up, Ernest. What Atul Gawande calls that incrementalizing. So you say, we're not going to solve it all today. And that's on line of what Kelly's saying, like, don't internalize this, don't own this. You got to enjoy your work. It's tough work that we do. You got to enjoy it. So incrementalize it, spread it out, call them tomorrow.
I think, that this has been great. And the discussion has been incredible. I do want to be respectful of everybody's time, but I mean, this topic is incredibly interesting to, I think, all of us for sure. And I think a lot of orthopedic surgeons who would have, missed out on this, and hopefully they'll be able to see it at a later date. I want to, again, be respectful of everybody's time, but you got one question I just want to incorporate from the chat here. As we talk about smooth, not solved, these are all very difficult things for us to do in like a fracture clinic where you see 60 to 100 patients and trying to rush people through. Are there other things that we can incorporate, like things like SSRIs or some pharmaceuticals or something else to kind of help the transition that we can incorporate into busy settings? Or do we need to, is this something we got to do an overhaul and change our fracture clinic setup and not try to see everybody in one day and one rest afternoon? And how do we spread that out? How do we incorporate what we need to do?
I can envision a situation in which we give SSRIs, or like maybe one for sleep or something, as an expediency. But for the most part, it's better to coordinate the care. If you recognize a problem, you don't necessarily have to own it. You can coordinate with the other doctors, like the primary care doctor.
Yeah, that's just what I was going to say. Is I'm good at identifying a lot of these things and less good at treating them. And we are always conscious that you're not going to be seeing the patient long term. So if there's one referral piece I always stay up to speed on is what the current primary care contact mechanism is within the health authorities. So how patients without a family physician, how you connect them with one reliably and ensure that loop closes. So I referred 4 people for primary care physician today out of my clinic. And then I send a specific letter saying that I'm concerned the patient has depression and would benefit from XYZ, but I defer to their expertise.
But we have to applaud anyone who's on this call and anyone who does trauma, because we've taken on a specialty where patients can never be the way they used to be. Look at Kelly's pelvic patient versus arthroplasty, where they're better than they used to be once they get their joint. So we take on the tough ones, team, so we can be proud of that.
And then, speaking of team, I got a question here from one of my team members, Dr. Jamal Al-Siri at MacOrtho. So I think he's on the call, wants to chime in here. Let's hear from you, Jamal.
Okay, thanks for the panel. It was great session. Actually, I joined Herman with doing trauma service with the Hamilton General Hospital. A lot of what's been discussed tonight, actually, this is what we see every day in our patients, like the depression, the cognitive status of the patient after a major trauma. And I do agree with all the points here about the family support and going to the depression. My question or comment, I think, is I find it a good point after almost immediately the second day or third day, having a chat with the patient, the family about setting up their expectations. I found that help a lot compared to if you don't talk to them, you waited 2 weeks to see them in the clinic and go through all the images and tell them that 2 weeks actually is a critical time. I find the first day or 2 days when you sit down with the family, tell them, okay, this is the injuries. This is what we expect. Tell them frankly what's their expectation. As much as you want to be optimistic, but also show them that it should be realistic expectation.
So Jamal, I agree with you. The problem is it's not the patient will take it in because they're still morphinized and recovering and sleep deprived. You can talk with the family and that will help them because the family can then educate everyone else. I agree with you. But in fact, I think the visit with the patient at clinic is way more positive with what you can get across to them. But I agree with your family discussion early.
I find it with the right, the family great, especially if they have a great family support. Patient, yes, most of the time they are still in ICU, but as you said, Dr. Buckley, setting up the expectation with the family, then which is great when the patient just wake up, see the family around, and they already been set up onto that expectation, and then you come back again the clinic, go through it again. And I think it's not just one time, it's the process, it's multiple with every visit, show them the expectation. Again, thanks for everyone.
And I just want to see, is there any other questions from the audience? Anyone wants to speak up?
Herman, can I ask a quick question?
Absolutely.
Yeah, it's Dan Ashford. So just a quick question. I know it's for residents who are involved, often we are asked to consent patients, with just that they're in acute setting when they have the trauma, and then handing it off to someone the next day or their service. And then the staff often isn't privy to that conversation, what's available, what's been discussed, or even setting expectations. From a staff perspective, what do you think are the most important things to talk to the patient about when you first meet them, often right before the OR?
One thing we have, and it's been years now, we've been talking to our patients and getting them involved in research studies early and consents early. One thing I feel strongly is you need to stay very general in your discussion, because if you get too specific and then the surgeon or whoever you're handing off to is going to be doing something slightly different, now you just create questions. And so generalities are key, and simple is key at the very beginning. Those are things. The other thing is that you mustn't contradict what's happened. You have to have a team approach. And then lastly is, I learned this from an older surgeon and a wise surgeon, and you shoot low, because then if the patient does better, but you never tell them they're going to be great, ever, ever, ever.
I'll go back to emphasizing the relationship. I think about, for me, again, it's been more hand emergencies on call, and the fellows tee them up, and I just trust them that all the important work has been done. And my job is just to let the person know that while their hand is different, for sure, it's going to be useful, and that I'm going to be with them on that journey.
I like that comment a lot about you're building a partnership kind of really early on. And if they, I think, have the impression very early that you will be with them throughout this process, that can really set the stage for setting some expectations as well. And they'll have trust very early on.
My adult daughter said, like, if my doctors, and she's got anxiety and migraines and has to see a lot of doctors, and she doesn't like a lot of her doctors, but she said, if I thought that my doctor cared as much about my success as I do, then I would love that doctor. So that's a pretty good way to put it.
Very good.
Awesome. And I think, it's been such a great discussion, but we've gone quite over time, but I think it's because there's so many interesting things to talk about. I just, if there's no other questions, I do want to be respectful that we've asked a lot of our presenters and panelists to be sticking around. And I just want to, close on some of the great thoughts we've had with us, and really want to thank, and I just want to see which one I'm sharing here. Are you guys seeing the screen or my slide notes?
That's
seeing the flyer.
Is this the right screen up there?
That's it. That's
Awesome.
the flyer.
Been great. So I just want to say, thanks to everybody for the great discussion and the panel. It was incredible just having you guys share your thoughts, your experience, and this is just so many things to think about. And I think one of the beauties of this whole series is that we have some time to think about all the things we've heard from these amazing speakers tonight and some of the incredible speakers we had earlier on in the series. Next week we're going to do something a little bit different, where we're just going to have a few cases built on some of the concepts we heard about. And I think not just next week, but I think throughout the series and really throughout your practice as we kind of move forward, how do we digest and incorporate some of the things that you've discussed tonight? And as researchers, especially, is what do we aim for? And I think the concept of trajectories is really interesting, consent. And I think a few things we've definitely discussed that are vast grounds for research moving forward. So I think lots of things for MacOrtho, COTS, and really the global research community in trauma to think about. And next week I want to give you a heads up. We're going to have some great panelists to discuss the cases. Jen Layton from Halifax, Amir Koshman from Toronto, and Ted Defescu from Manitoba are going to be our panelists to sort of discuss trauma cases, expectations, and hip fractures. And we look forward to having you guys join us next week. And I just want to thank everybody once again for joining us tonight. And thank you to our panelists and the audience. And Prism.
Thanks, Herman. Super, Herman.
Thanks, everybody.
Thank you.
You all.
Thank you, Herman.